Now it's my pleasure to invite our friend from USA, Eric Bothun, who will be talking about superior oblique plication. He's going to share some tricks with old and new friends. Over to you, Eric.
All right. Thank you for the opportunity. As I said here, a new trick with old friends. I think some of the joy of coming to these meetings is we appreciate relationships and learn new things. And I have certainly enjoyed coming to India for some time and appreciated many relationships with friends, and along the way learned new tricks on muscles. And certainly the superior oblique is an old friend. But I think all of us that operate on the superior oblique can understand that it can be tricky or has risks. There are both surgical technique and in choices. We have to be careful in managing the superior oblique. We understand that it is a critical player when it's dysfunctional, either in versional or torsional strabismus. And likewise, when we do approach it, we understand and respect that we can influence vertical and torsional strabismus by operating on the superior oblique. I'm from Minnesota, USA. It's right in the middle of the United States, up in the north, and one of our historical strabismus landmarks in terms of careers was a Dr. Fink. And Dr. Fink is not very well known in strabismus, but back in 1962, he was the one that described the courses of the inferior oblique and the superior oblique with quite vivid detail. And it was after he described that the anterior fibers of the superior oblique probably are the ones that have the biggest torsional impact. 2 years later, there is the superior. 2 years later, Harada Ito said, well, let me use that new understanding and move those. And so the Harada Ito procedure became our first step at intervening for purely a torsional strabismus in a very articulated way, not trying to change horizontals or vertical. And he grabbed the anterior fibers. It was described about 2/3 of it, and he pulled them anteriorly and temporally to correct. So this is a diagram that's been done. You see number C down there, pulling the fibers anteriorly and temporally to create torsion on these fibers. And as you know, we've been doing these for a long time. There are risks at the Harada Ito, but it's been a good friend for us trying to intervene. It oftentimes accomplishes between 5 and 10 degrees of intorsion. That effect typically slides back with time. Your immediate effect is typically stronger, and then it slightly weakens. So sometimes 5 to 7 degrees is what I expect out of a Harada Ito. And then in 1974, the Fels modification. He said, well, why don't we take part of that same tendon, take it and disinsert it, and bring it over to the lateral rectus muscle. And he reattached it about 8 millimeters back, and that became, I'd say, commonly the Fels modification, something we've been doing for many of the last decades, and correcting torsion up to 10 degrees. I will admit in my hands I don't usually get 10 degrees to last out of the Fels modification. Dr. Holmes was a partner I joined 8 years ago at the Mayo Clinic, and he was big into adjustments. I've always done a lot of adjustable post-op procedures, but I didn't do it very often for my superior oblique. I just did the Fels variant. I expected if I needed some good torsion, I'd do it and I'd get 5 to 7 degrees and I'd be happy. But I will admit, having this adjustability became attractive to me. But what I did not like about Dr. Holmes's techniques is you're adjusting way back in this quadrant. It's hard to adjust the superior oblique. It's mucking with tenons. He would put a traction suture to pull the eye down post-op. The patients are uncomfortable, and I was uncomfortable. And so I didn't get into adjusting too many superior obliques, but I realized both on the small end, if you have on the synoptophore someone with a 4-degree extorsion and you want to nail it, because maybe they have a history of retinal disease and you really need to get a torsion exact. Or if they have 12 degrees of extorsion, and I know a normal Fels modification may not get it all, I was tempted to try. And so, those of you that know, over the last couple of years, I've tried a modification. Dr. Ameri et al., back in 2009, described plicating the anterior fibers, doing a third, and instead of bringing it forward like Harada Ito, instead of bringing it over by the lateral rectus, they did 2 patients in the operating room where they plicated it and looked in the operating room at the fundus to determine whether they got enough effect. They called it adjustable, but I think what they would do is look in the operating room, look at the torsion. If they needed more, they'd plicate more. I said, all right, I need a new solution. And so I decided we need a more tailorable, adjustable, accessible way safely to adjust for torsion. And so I started plicating with this technique. And you see, I still separate a small amount of fibers. It's typically, I don't usually do a third. I think a third is too much and risks more vertical deviation. So I just get that amount. If you're used to working with superior oblique and doing Harada Itos, this might be for you. If you don't usually touch the superior oblique, respect it and maybe get more training before you do. But I tend to find maybe 10, 15, maybe 20% of the tendon. And I will measure a certain amount up in our, now we're plicating rectus muscles all the time. It's the same approach here. You march up the tendon a certain amount and you plicate it, and then I reattach it just in front of where it inserts. You can put a hook on it and feel that's where it's inserting, and you reattach it there. And then I bring another one, like a dog leg or a hemi hangback, and I reattach it up front. So this is my video of this. This is the picture showing, but I want to jump to this, and I'll try to get it to play.
So at this point, I'm placing at 12 millimeters up the length of the superior oblique.
12 millimeters, large amount of torsion for this patient.
Micro stitch, S29 needle. Once it's secured at that location, I can imbricate both sides of the tendon, even pull it with the small one, and appreciate that is the insertion. So just temporal to that, I will take a small bite carefully, imbricate a small bite of the sclera with each of the needles of 6 micro. So we have both sides of the vicryl coming down and attaching just temporarily. Adjusting back here is difficult. So the next step of the plication process makes it so much easier is to use what we know about a hemi hangback and securing this up front. So I ask the assistant to get a small hook, and I'll get a small hook to me, and then I will take both of these stitches that I just imbricated here and reattach them up front. Right next to it, I'll place the other one.
I like noose adjustable technique.
Fibers, that complex pulls temporally, and then it's extended up to its new insertion site. At this spot, I put in, so we have an imbrication back, a plication back here, extending up to a hemi hangback as noose technique.
It's fairly close to the lateral rectus muscle temporally.
Of recession that I might allow. Caliper. This is a 12 millimeter plication. I know this patient has a large degree of torsion. There's no reason to leave a lot on the table. So I am going to imbricate this at 7 millimeters. Why 7? Well, I can give back from 12, I can give back 7, that would leave me 5. If the patient had a funny result from there, you can always cut it. But I know I want an in-torsion effect. So let's leave this patient with a range from 5 to 12 on each eye. Now, at this point, you can see, here's my noose knot, here's the pole suture knot. This is adjustable to let varying amounts. I can let this come back and slide this up, letting more of a hangback to be communicated, thus less of a plication. Here, there's my anterior fibers pulled torsionally. Here's my hemi hangback, the noose is secured here. It's secured up front with the noose in an adjustable way, easily accessible, and we have it changed.
You see the corneal markings as Dr. Santa described on the cornea. So How is this done for me? I've probably done over 100 of these now for varying amounts of torsion with purely torsional strabismus and or associated with other vertical. And I decided to look back, and I have these two manuscripts that are grouping these two. Some tips along the way. Mark the corneas, as been articulated before. Carefully isolate the superior oblique. When you isolate the superior oblique, you need to separate these fibers as far nasal as you can. I use the Barbie, and I put the anterior fibers on two large hooks, and I take the Barbie and push it all the way, the posterior fibers back, and then I get in a forceps, and I pull away all of the posterior fibers, because I try not to affect those. I don't want a Brown syndrome. And then as you saw here, the rest of the case. At the end of the case, double check a Saunders test is what I do. I grab the infratemporal limbus, and I push up and in and make sure that there's not a Brown syndrome. I look back at only the patients that had this procedure and or maybe with a horizontal component, but no associated verticals. And there were 14 of those isolated. This was just accepted to APOS. Because it's being published, I didn't want to give all the details here, but stay tuned. It will be in the Journal of APOS. I'll give you a quick synopsis just about a couple of things. I see them post-op, and I do an adjustment. As was articulated, we expect to have a little overcorrection. For unilaterals, I'll be happy with like 5 degrees of intorsion. Bilaterals, a little bit more. And I adjust these in the treatment room. For those of you that do adjustments, especially with the noose, you understand how successful that can be. So, and again, so there are times where you have vertical strabismus and other factors that you may choose other surgery if there's a meaningful vertical. But for me, I go through now and I can tailor my approach. If I have a patient with 4 degrees of intorsion, I'll generally plicate. I often take off 1 millimeter. Why? Because I reattach it just in front of the superior oblique. So there's always a little bit of an advancement. You can't reattach it where it reattaches. So I often cut back a little bit. And obviously the bigger amounts of torsion, the more I might be cautious and allow my flexibility later. You can adjust it and plicate at 12, but hang it back 5. And let yourself afterwards pull it up, which is easier than getting it to go back. You can. There are ways with Saunders and things get it to relax afterwards. But you can choose unilateral, bilateral approaches and make it very custom for the amount of torsion you have. And so my patients, again, this is coming out, my series from 2 to 24. The 2 was actually a retina patient with very finicky torsional issues, and so that's very minimal. And I look back, typically you can have a very, very tailored approach. Jonathan Holmes said for each amount of advancement, 1 millimeter gets you about 1 degree, and that's what I'm finding. In addition to that, you may get about a degree or a prism diopter or half a prism diopter of vertical effect. Almost always, patients have meaningful torsion. There can be a slight vertical of a diopter. If it's 0, still do this. But if there is a hyper, do the bigger amount of application, or do the application in the eye that's a diopter high or 2 diopters high. If you have a bigger vertical deviation, you're going to be choosing another surgery, whether inferior oblique or superior oblique tuck or something else. But keep in mind, if there is a microvertical, you do this on that side, because I maybe will see a half a diopter or a diopter of a vertical change. Doesn't seem to affect horizontal deviations. I've done them with like a BMR or other combinations, and I've had a great response. Initially, it's a little bit strong. I get maybe a little bit more than 1 degree per millimeter, but as it relaxes, that's about what I get. And again, Dr. Holmes suggested this with his advancements technique. But why do I like this? I like this because I have a tailored way, rather than expecting the Fels variant, a tailored way to correct torsion, and allows me even high degree. I had one patient that 30 degrees of intorsion, and I nailed it. 24 degrees, 18 degrees. To me, it's allowed me the ability to successfully do this in a way that's easy to adjust post-op. And that's what we just talked about here. So it is retrospective. This is a small amount. The second publication that should be coming out soon is this combination with other verticals. What about doing a superior rectus on the same eye that in a patient that has a hyper, worsen up gaze, and also has a little bit of extorsion? You recess the superior and bring down the vertical, you might make their torsion worse. And this allows you in the same wound to do a little bit about. There's combinations, you'll see that coming. So just conclusion, this allows for a targeted correction of extorsion. I presented this last year in Delhi and was welcome back to talk about it today. And it's just a new technique, a new trick on an old friend, the superior oblique, with old friends in my colleagues here. One other plug, just I have 6 seconds, is I've also enjoyed being at the Mike Moore, and we have a podcast every 2 weeks. You can go on YouTube and see a variety of subjects that have to do with ophthalmology, and it's been a lot of fun to learn how to be a spokesperson on a variety of areas. So if you're interested in podcasts, you can tune in and do that, and I do thank you to be back with old friends.